evening topic is common mistakes in management of hypertension, and we are going to discuss this in detail. And we have Dr. Rajesh Kumar Jha, who is practicing in Darbhanga. He is a medicine and physician. So, sir, I request you to please.
Good evening, all. Today's topic is much more relevant to our own practice and to the for the benefit of the paramedics who are helping us. Common mistakes in management of hypertension. What are those? First of all, is inappropriate measurement of blood pressure, then lack of adherence of especially in elderly, then incorrect diagnosis, then given monotherapy who requires combination therapy, and then medication contraindicated in specific diseases. So we will discuss each one by one. First of all, inappropriate measurement of blood pressure. Next. Overestimation of blood pressure. Overestimation of blood pressure by just 5 mm of Hg can lead to inappropriate treatment of approximately 30 million patients. You can see that only 5 million, we are at times we are very subtle about measuring the blood pressure. 5 millimeter of Hg क्या होगा, इतना बढ़ भी जाएगा तो उससे क्या होगा, लेकिन इससे डिफरेंस क्या होता है? देयर इज इनअप्रोप्रिएट ट्रीटमेंट. यदि आप 5 मिलीमीटर ज्यादा बढ़ा करके किसी का ब्लड प्रेशर बताते हो तो 30 मिलियन पेशेंट्स का हम लोग इनअप्रोप्रिएट ट्रीटमेंट प्रिस्क्राइब कर दिया करते हैं. सो unnecessary treatment and cost is there. Potential side effects of the medications is there. Mislabeling of hypertensive with attendant psychological issues, ये भी बहुत बड़ा इशू होता है कि लोगों के दिमाग में एक साइकोलॉजिकल इशू हो जाता है कि आपके पास मैं हाइपरटेंसिव हो गया. ये बहुत बड़ा इशू उसके दिमाग में बैठ जाता है कि मैं हाइपरटेंसिव हो गया, अब मेरे को तरह तरह की बीमारी होगी. तो इस चीज से बचने का कोशिश करना चाहिए. Then what will be the scenario with underestimation of blood pressure? Next. Underestimation of blood pressure by 5 mm of Hg will mislevel approximately 20 million patients with pre-hypertension when they would have true hypertension. So underestimation is equally more dangerous. It leaves 20 million patients with pre-hypertension when they are true hypertension and they need treatment. So what is the other common mistake? We do not use ideal cuff size. Next. In the blood pressure measurement, there is a BP machine, a sphygmomanometer. The ideal cuff should have a bladder length that is 80% and the width that is at least 40% arm. It should cover at least 40% arm circumference. But person with average body weight, it is okay. But if the patient is obese, his arm circumference is more, then जो डे टू डे एक्टिविटीज में जो हम लोग बीपी इंस्ट्रूमेंट का यूज करते हैं तो वो it may not be sufficient, and bladder length is much more important for accurate measurement of blood pressure. Most present day curve have an index marker which and a range marker which can assist in preventing miscuffing without the need for measuring the arm circumference. Once the index marker is within the range, the cuff is of appropriate size of the patient. This is also recommended by American Heart Association. Then selection criteria for next. What is the selection criteria for BP cuff for measurement of blood pressure in adults? So small adults are circumference should be 22 to 26, adult 27 to 34, large adults 35 to 44 centimeter, and adult thigh. In cases of aortic regurgitation, we usually measure arm as well as thigh blood pressure. So in that case, 45 to 52 centimeter cuff size is sufficient. Then what next? Then what are the 6 common errors that can lead to inaccurately elevated blood pressure reading? Things are small, but you can see in this that how much we are ignoring the facts about the accurate blood pressure measurement. Poor sitting posture of the patients, unsupported arm of the patient, wrapping the cuff over the clothing, a cuff that is too small for your arm, then patient is talking, having a full bladder. Most important and interesting thing. If patient has full bladder, then there may be a inaccurate blood pressure measurement. So incorrect diagnosis brings more complications. Next. Incorrect diagnosis brings more complications. So what are those? Misdiagnosis. A misdiagnosis could result in delayed treatment, which may cause other complications or more severe illness. An inappropriate follow-up plan was one of the common reasons for misdiagnosis. Then, reasons for inappropriate follow-up include lack of follow-up, incorrect interval for follow-up, no documentation of the follow-up. So, next, what is the hypertension diagnosis and management error taxonomy? At the time of diagnosis, if hypertension diagnosis is there, it may be misdiagnosis, it may be incomplete diagnosis, or it may be missed diagnosis. So if SVP is less than 140 by 90 mmHg and there is no history of hypertension diagnosis, no history of antihypertensive medication, but you are diagnosing it as hypertension, then it is misdiagnosis, incomplete diagnosis. Hypertension diagnosis and there is no record of blood pressure, then it is incomplete diagnosis. No hypertension diagnosis or misdiagnosis. If patient has blood pressure of more than 140 by 90 and there is no hypertension diagnosis, then it is called misdiagnosis. Then at the intervention part, if omission of essentials and intervention contraindicated. So omission of essentials होगा medications. If medication is needed and you are not prescribing, then omission of essential. Hypertension diagnosis 140 by 90 and no antihypertensive medication prescribed, no history of use of antihypertensive medication, then it is omission of essential. Then patient teaching. Hypertension diagnosis more than 120 or diastolic more than 80. No lifestyle modification related patient teaching. There should be always patient teaching that it is misbelieved that blood pressure should be 120/80 in each and every condition in every time of the day, whether measured by 1%, 2%, different persons. But there is, we people understand that there is subjective variation at same time. If many people used to measure the blood pressure, different variations, different readings are there. So it should be told to the patient that it is not like that, 120/80 is always the blood pressure. It is the range 120 to 140, it is acceptable in systolic. It is acceptable that 80 to 90 in diastolic, it is acceptable. But you need some lifestyle modification definitely, like salt restriction, regular exercise, and probably some meditations also. Then next, follow up. What is the part in omission of essential? So follow up case antihypertensive medication is prescribed, but follow up is not documented. So it is equally important that follow up should be told to the patient that he should home monitor the patient, the blood pressure, and it is equally essential to come at time. What are the errors encountered in hypertension management? So, as I have told already, that in terms of errors related to hypertension management, the rate of error of omission was higher than inappropriate treatment, prescribing contraindicated medication. So, in our part, if you follow documents and data, there is error of omission, rate of error of omission is much higher than inappropriate treatment. We are prescribing medications as well as for the patient teaching. ये कहीं पर में लैग करता है, लेकिन इनअप्रोप्रिएट ट्रीटमेंट देने से हम लोग थोड़ा सा बचते हैं. हम लोग अच्छे हैं कि ये इनअप्रोप्रिएट ट्रीटमेंट कम से कम हम लोग नहीं कर रहे हैं. Then medications errors are most frequently reported type of error by healthcare providers, and omission of medication is most frequent type of medication error. So next, blood pressure pattern based on office and out of office measurement. So what are those? Normotensive, no hypertension in office, clinic or healthcare setting. Then no hypertension in home, non-healthcare and other settings. So sustained hypertension in both as well office as well as home setting. Then what is masked hypertension and what is white coat hypertension? These terms should be understood. That masked hypertension is if there is no patient comes to you and there is no hypertension, but he reports that in home setting there is always blood pressure in hypertensive range, and opposite is there with white coat hypertension. In office or our clinic, patient is having hypertensive range blood pressure, and in home setting they have no hypertension. So we should be also there is also a error in medication contraindicated in specific comorbidities. What are these? Those? Next. Next. Indications and contraindication to major classes of antihypertension. So as you can see that there are various classes of antihypertensive, diuretics, beta blockers, calcium antagonist, ACE inhibitors, angiotensin receptor blocker, and alpha blockers. These are the hypertension which are used by us. As you all are familiar that thiazide-like diuretics are indicated in congestive heart failure, elderly, isolated systolic hypertension, African origin patients. There is a specific contraindication to thiazide-like diuretics like gout and pregnancy. Possible contraindication is pregnancy. Then in cases of loop diuretics, in-stage renal failure and congestive heart failure are the indications for their use. But it is also, it should be also avoided in cases of dyselectrolemia and in cases of old age. Diuretics, anti-aldosterone, just aldosterone, these are epinephrine. These are indicated in congestive heart failure as well as post-MI cases, and there is compelling contraindications in cases of renal failure and hyperkalemia because these are potassium sparing diuretics and increase the level of potassium. Beta blockers are indicated in angina pectoris, post-MI, CHF, pregnancy, tachyarrhythmia, and it is contraindicated in asthma, COPD, AV block. And peripheral vascular disease, possible contraindication, glucose intolerance is possible in contraindication, and athletes and physically active patients should also avoid beta blockers. So most commonly beta in our day-to-day practice, it is seen that beta blockers inappropriately and inadequately used in cases of COPD and asthma. So likewise, calcium channel blockers, dihydropyridines, amlodipine and others, cilnidipine, these are the very wonderful drugs used in various diseases and probably most commonly used in elderly cases and most safe in my view, and these should be avoided in conditions of tachyarrhythmia and congestive heart failure. Then calcium channel blockers of verapamil and diltiazem class, dihydropyridine group. These are indicated in unstable angina, supraventricular tachycardia, carotid atherosclerosis, but it should also be avoided in conditions of second or third degree heart block and congestive heart failure. ACE inhibitors like are indicated in congestive heart failure, LV dysfunction, non-diabetic nephropathy, type 1 diabetes, and proteinuria. And compelling contraindications are pregnancy, hyperkalemia, bilateral renal artery stenosis. Likewise, angiotensin receptor blockers are indicated in cases of type 2 diabetes, proteinuria, diabetic microalbuminuria, LVH, ACE inhibitors, in S inhibitor induced cough. So these are also contraindicated in pregnancy, hyperkalemia, and bilateral renal artery stenosis. Alpha blockers are indicated in cases of BPH and hyperlipidemia, and these are contraindicated in cases of orthostatic hypertension, and possible contraindication is congestive heart failure. So we should keep in mind the indications and as well as contraindications. At least we should avoid in contraindicated cases. But next, I last uh, slide, please. No. हाँ हाँ ठीक. There is a bottom line in cases in we discussed this, but contraindicated antihypertensive medication related errors were identified in 11.6% of doctors with diagnosis of hypertension and asthma. As I told, it in our day-to-day practice, it is also seen that in cases of asthma, we or our colleagues are prescribing beta blockers and contraindicated medications most of the times. So given monotherapy, who requires combination therapy. So it is not like that BP, any one drug is given to the hypertensive patient and it is sufficient. In various trials and various data, you can see that BP control rate are suboptimal with monotherapy. More than 75% of anti-hypertensive patients do not have adequate BP control with monotherapy. So they require combination therapy. Next. Next point of concern in treatment of hypertension is non-compliance and non-adherence. So you will be surprised that only 1 in 7 people with raised blood pressure have it adequately controlled. See the data. Only 1 in 7 people with raised blood pressure have it adequately controlled. And 1 in 4 patients on antihypertensives are not taking prescribed medicine. See, either they are taking for 1 to 2 weeks the prescribed medication, then they are coming to the original one, whether it is controlling their blood pressure or not. Next, adherence in elderly people is becoming a growing issue of concern. Reasons for non-adherence in elderly are decline in their cognitive functions, decline in physical well-being, multiple comorbidities, and lots of pills they are taking, and complex treatment regime. These are the few reasons for non-adherence in elderly. Then, next, as we all are aware that the silent killer nature of the hypertension should be understood to us and the patients also. The silent killer nature of hypertension has an impact on patients' adherence to treatment for the condition. And like many other non-communicable diseases, hypertension does not show signs of manifestation until the end organ damage that can appear years after a diagnosis becomes symptomatic. So it should be emphasized to all the patients that if their blood pressure is not adequately controlled, it will be a definite end organ damage. It is only a matter of time, years. And high impact of hypertension, you can see that by 2025, it is estimated that more than 1 billion people globally are living with high blood pressure. More than 1 billion people globally are living with high blood pressure. So we have a huge task in front of us. So we should train our staff to take blood pressure in adequate and correct method, and whenever there is time, when we should teach our students also and teach the patients also about the deadly nature of the hypertension, and by avoiding common mistakes in management of hypertension, we can treat them better and better. Thank you.
Thank you, sir. Thank you very much for your nice guidelines as well as nice topics, sir. I would like to thankful to Dr. Shahabuddin sir also. Sir, thank you very much for your kind presence and organizing such a fantastic webinar. With this, I would like to hand it over to you, sir, Dr. Shahabuddin sir. शाहबुद्दीन सर, आपका म्यूट है सर, आप थोड़ा अनम्यूट कर दीजिए सर. Yes, sir. Sir, over to you, sir.
Thank you, sir. Thank you for sharing your wonderful knowledge and giving your precious time. We are very obliged to know our mistakes we are doing on day-to-day basis in diagnosis and management of people with hypertension. And thank you everybody for joining today's talk. Now we should end here.
Thank you very much, sir. Thank you very much for your kind presence. Good night, sir.
Good night.
Thank you, sir.
Good night, sir.
Good night.
Also interfere with diagnostic procedure. COPD and heart failure patients have similar presentation. In aggravate heart failure symptoms, further impair quality of life, contribute to the burden of hospitalization and mortality as the main cause of readmission at 1 and 3 months. May affect use of treatment in heart.
Yeah, Aditya sir. Hello.